Welcome to Module 2 of the Assist to Succeed Dental Assisting program. Today we will focus on four-handed dentistry and a number of other topics. But let's jump right into it. I'm Dr. James Drake. I'll be your host and narrator for today's module. Just as a review from the last module, we just want to go through the anatomy that you see here. These are the centrals. These are the laterals. This would be tooth number 1, tooth number 2, tooth number 3, tooth number 9, tooth number 16, 17. Remember your big landmarks of 3, 14, 19, 30, 6, 11, 22, 27, and you're just 2 teeth away from any other tooth number in the mouth. If you can remember those 8 numbers: 3, 6, 11, 14, 19, 22, 27, and 30. This would be the hard palate, the soft palate, tonsils, uvula, pteromandibular raphe back here, the lingual frenum, the labial frenum, vestibule. Okay. Remember, go through tooth numbers again with yourself as if you were looking at a patient's mouth. This is the patient's right-hand side. What tooth number is that? Tooth number 2. Tooth number 15. If you're confused, think about wisdom teeth. Tooth number 8, 9, 6, 11. That would be 17, 18, 19, 22, 27, 30, 31, 32. Know those tooth numbers cold. You've got to know those tooth numbers absolutely cold. Do you remember the name of this gingiva here? This would be the attached gingiva. Something we didn't talk about last time, this little point of gum tissue up here is called the papilla. There's a papilla between every one of these teeth. Papilla, papilla, papilla. What tooth number is this? Well, you know that this tooth number here is going to be 27, 26, 25, 24, 23, 22. Okay? This tissue here, these are the lower teeth. This is going to be the labial frenum, labial frenum. This is the unattached gingiva. This is the mucogingival margin. So this is mucosa, gingiva, the mucogingival margin. Okay? Unattached, attached. Okay? This would not be a drill. It would be a high-speed handpiece. You remember talking about our PPE and the short video we had on that? Put on your other PPE and adjust everything, including your chair, before you put on your gloves, just to review. All right, let's jump into some new material today. So, a couple of things I want you to notice about this picture here. I do want you to notice this hairstyle would not fly in my office. When she leans forward over the patient, it's going to flop down into her eyes. It's going to drop onto the patient. This is an inappropriate hairstyle for my office. Some offices may allow that, but it wouldn't fly in my office. It needs to be pulled back, tight, all kept neat, tidy. There's a lot of things in dentistry that you can get right accidentally, and one of those would be putting this bib on properly. There's two sides to the bib. Um, so if you are not sure which side of the bib, you need to ask your instructor, but one side of the bib is shiny and one side is dull and absorbent, and that absorbent side is what needs to go up so that we can get lots of water and things on it, but it doesn't get on the patient's clothing. Some offices do require blood pressure. So again, the hairstyle thing, shiny side, dull side. So again, there's two ways to do it. You might get it right accidentally, but if you know your stuff, then you don't have to worry about it. Okay. So taking blood pressure, this is a short video on how to take blood pressure. This is something you should practice. It's not something that comes easily to everyone. My office, we have an automatic blood pressure cuff, so I don't require my assistants to take blood pressures manually like it's going to show you here, but some offices may require it. Manual blood pressure taking is more accurate than an automatic cuff, so your office might require that. So we'll go through that now.
When taking blood pressure, have your patient seated with arms supported and extended at heart level. Palpate the brachial artery to feel for the patient's pulse. Take the patient's brachial pulse for 30 seconds and double the number for a minute reading. Add 40 millimeters to your reading to give you your inflation level. Prepare the cuff first by expelling any air by opening the valve and pressing gently on the cuff. Place the blood pressure cuff around the patient's arm approximately 1 inch above the antecubital space, making sure to center the arrow over the brachial artery. Tighten the cuff around the arm, making sure the cuff is tight enough so that you can only get a finger between the cuff and arm. Use the Velcro closure to hold in place. Position the earpiece of the stethoscope into your ears so they are facing forward. Place the stethoscope disc over the site of the brachial artery using slight pressure with your index and middle finger. Grasp the rubber bulb with the other hand, lock the valve, and inflate the cuff quickly to the noted reading. Slowly release the valve and listen through the stethoscope for the first distinct thumping sound as the cuff deflates. This will become your systolic pressure reading. Slowly continue to release the air from the cuff until you hear the last sound. This is your diastolic pressure reading. Record the reading, indicating which arm the reading came from.
So things you might not be familiar with, so you use the term antecubital space. That's the front of the elbow. So the blood pressure cuff needs to be just above that, so you have room to place your stethoscope. And diastolic, so there's two numbers, diastolic and systolic. And diastolic is when the heart is pumping, and diastolic is when the heart is not pumping, and systolic is when the heart is pumping. So when the heart squeezes, you get your systolic, and when the heart is relaxed, you get your diastolic pressure. So not terrifically important, but something you should be aware of. Some offices may put a lot more emphasis on it than others. So anesthetics. Okay, topical anesthetic gel is shown here. It's a little gel that you use, a cotton swab usually, or a cotton tip applicator, some offices will call it, to put on the tissue. Some offices require the assistant to do that, so you need to be aware of where your doctor wants you to put it depending on which tooth you're working on. So there's another short video about applying topical anesthetic.
Applying a topical anesthetic. Open the container of topical anesthetic. Place a small amount on the cotton-tipped applicator and then replace the cover on the container. Determine the injection site and gently dry the site with gauze. Place the cotton tip applicator with ointment directly on the injection site. Allow the anesthetic to remain on the site for 3 to 5 minutes.
So 3 to 5 minutes is the important part there. And we'll move on. So where would you apply topical? On the maxilla, meaning the upper jaw. You usually just go right over the tooth to be treated. So this illustration is a light behind a model, and you can see the roots of the teeth inside the bone. This is just a part of the model, the screw here, but you would, like if you were to gonna be anesthetizing tooth number 6, you would go over right over tooth number 6 up in the vestibule, in the buccal vestibule. Okay? If you were going to be anesthetizing tooth number 9, you would go in the labial vestibule over tooth number 9. So right up in here. The lower teeth, often it's in the back in the pteromandibular raphe area, because that nerve that goes inside the bone sends out branches to all these other teeth. So you don't usually give anesthetic in the vestibule for lower teeth. Sometimes for just the front teeth, you can give it over these premolars, numbers 20 and 21 and 28 and 29, but most often you'll give it in the back. So again, that would be for the doctor or the hygienist in some states. So sometimes you may have to do it on the palate as well. So again, notice how all these teeth are fed by this nerve on the bottom. So these blue circles represent where you would give that, place topical for that injection site for the lower teeth. Okay, see that little red triangle there is where that would be given as well. So this is the pteromandibular raphe, that line right there, and it's right in front of that. So that's where you place the topical for that. So I would like you to look at your classmate or your spouse or someone in your home. Just have them open and hook their cheek back and take a look in there and see if you can identify that spot. Septicaine, xylocaine, they're two most common local anesthetics. Lidocaine is a very common one. These come in carpules, little glass carpules that have a rubber stopper on one end and a spot for the needle to go in on the other end. And you should pick up one of these syringes and learn how to load carpules and needles into the syringe. There are longer needles that we use. There's generally two sizes we use in dentistry, a 27 gauge and a 30 gauge. In my office, I don't use the word needle. I use the word tip. I'd like a new blue tip or a yellow tip. Those are very common colors for them to be color-coded in. They may not all be that way in your office, so learn which is which. The longer one would be, and larger would be 27. So the smaller the number, it's a little strange sometimes. The smaller the number, the larger the needle. So you need to be aware of that. So this would be what you'd need for anesthetic. So like I said, the 30 gauge or the short blue tip is typically for upper teeth, and the 27 gauge, the yellow long, is for the lower. And we call it a block when we block many teeth rather than just one tooth. So if the doctor says, I gave a block, then you'll know that they got multiple teeth numb. They block the nerve at a spot that gets many teeth. So this is something you should practice. You need to hold this in your hand and actually practice doing it with a syringe so that you're familiar with how it works. Because this is not, it's not obvious how this works, but here's a short video that helps you understand it.
A good dental assistant must be able to know how to prepare the local anesthetic syringe. Here you see the three things that you will need: the local anesthetic syringe, a needle or a tip is also known as a tip in front of the patient, and a carpule of anesthetic. The needle, again, I don't call it a needle in front of the patient, I call it a tip, is opened by taking the short cap off that exposes the part of the needle or the tip that's going to go into the anesthetic syringe. Here you see that the handle has a plunger that is spring-loaded. You can see, if you look very closely, we're going to zoom in on it here, and you're going to see this harpoon right here. It's a point, and it's much like, it's called a harpoon that you would stab something with. And it's going to stab that little plunger, that little gray plunger that's made out of rubber inside that carpule of anesthetic. So the carpule of anesthetic has two ends to it. You can see the gray plunger there, and this end is where the needle will go, and this end is where the harpoon will go. So I'm going to rotate the syringe so you can see this is the needle end, and it will go there, and this is the plunger end, and it will go into the harpoon. So the needle is threaded onto the syringe, and it's screwed on tightly. If it's not tight, the anesthetic will leak out around it, and you can see that the threads are completely disappeared and the needle is tied up against the syringe. The little black triangle is for use by the operator and is of no consequence to the assistant. You can see here that the handle is spring-loaded, so I'm going to retract it with my little finger and my thumb, and as I press and grip it tightly, it retracts the handle and pulls the harpoon in. This will give me room to place the carpule of anesthetic inside the syringe. It will engage the harpoon when I release the handle. Here you'll see that as the harpoon presses the carpule forward, it will engage the needle into the needle end of the anesthetic carpule. Now, one of the most important things is to notice that that harpoon is not engaged into that rubber stopper, that plunger yet. You can see that because it draws back very easily, so I'm going to smack it very hard with the palm of my hand. You notice the harpoon is engaged into that gray plunger, and I'm going to test that. You can see it's still not engaged, so I hit it again. Now it's engaged, as it will not draw back when I tug on it. And now I'm going to remove the cap for the needle, and I'm going to make sure that I've engaged it properly. Sometimes if you don't do this right, you will bend the needle at this point. So you need to you'll see a small drop of anesthetic coming out there. That way I know that the needle is engaged into the carpule and is ready for delivery to the operator. The operator will receive the anesthetic and administer it to the patient. Now, once the anesthetic is complete, we need to get that needle where it's in a safe place. So we have the cap here, and if we try to just, place it back in the cap with one hand, we're very often going to poke ourselves. This is a good way to get a disease and get a painful injury. So the foolproof way to do this is to just lay the cap down and slide the needle in. Once you pick it up, you'll know that the needle is protected by the cap, and you can tap the cap into place very easily and safely. There are any number of different methods and little gadgets for recapping a needle. This is the only foolproof way, and it is the least expensive way to recap a needle, and you will never get poked if you will safely recap the needle without holding the cap. So, once the needle has been capped safely, we need to unload the syringe and perhaps load another. This may be done by the operator or the assistant. We need to disengage the plunger and the harpoon. So we retract it back, you'll notice that the plunger stays inside the carpule and the harpoon is retracted into the handle. Now we need to disengage the carpule from the needle, so we just slide it back, and now the syringe has a window on the opposite side to help you just press the carpule out of the syringe. And if it's done properly, the carpule will basically just fall out of the syringe. We're now going to do this in full speed, so this should take you just seconds to load the anesthetic syringe. We're going to uncap the needle, screw it onto the syringe, retract the handle, drop in the carpule, slide it up into the needle, and engage the harpoon, and deliver to the operator. A very frustrating scenario is if an assistant loads an empty carpule into a syringe and presents it to the operator. You need to know how to see the difference between an empty carpule and a full carpule. Notice here, there is no plunger. The plunger is all the way down to the end. Here, the plunger is right at the very top. And that's the way you can tell if the carpule is full or empty. You always load a full one for the operator.
Okay, so once again, you need to pick those up and get yourself used to doing that. You can't just watch this video and expect to know how to do it. Okay, something that's critically important in dentistry, especially modern dentistry, is the isolation of the teeth and moisture control. The new composite material, and I say new because it's newer than the old amalgam. Amalgam, the silver fillings, the metal fillings, did not require the isolation and moisture control that the newer materials do. So it's critically important that we learn how to isolate. Most common way is to use cotton rolls, and it's the simplest, fastest, cheapest way to isolate in many cases. So they're just really simple to use. One thing you do need to be aware of is when you place this cotton roll up here in the vestibule, for example, if that is dry, when you pull that cotton off, you can tear that tissue and create it feels like a burn to the patient. So it's kind of considered a cotton roll burn, because you can tear tissue away from off the top layer of skin off, essentially. And so you need to be careful with that. So the way to avoid that is make sure that when you take the cotton roll out, that it's wet. And you just take your air water syringe and just fill that cotton roll full of water, and then it will slide out really easily, and you don't tear off that bits of tissue and injure the patient. So there's a good example of when it comes off, they just pulled it out, and this is a few days after it's been healed, but it's just a cotton burn, essentially, or tear. So make sure that it's wet before you take cotton or gauze out of the mouth. Another way to isolate teeth and keep things dry is a rubber dam setup. This is something you need to be familiar with. Offices will have different shapes of frames and different shapes and different styles of clamps. These are the clamp forceps and the punch to punch holes. Usually I prefer, as my preference, that they punch one hole for the tooth that I'm working on. There are times when I'll be working on several teeth, and so I'll have them punch several holes. But you need to be familiar with rubber dams. And again, the only way to learn that is to get the materials in your hand and practice with them. So you have the punch, the setup, the frame, the dam itself, and clamps. So you have all those items to set things up. And these clamp numbers are going to be different for every office. Really, I only have 2s and 3s in my office. This particular office has a 14A, and dentists will have their own preferences, so don't get too stuck on these clamp numbers. You need to learn the ones at the office that you're working in. So these are common ones. You use this to see this. The size of this clamp would fit nicely over a premolar. This one's larger for a molar. This one's larger for a molar. Notice this one has little wings on it. for some reason manufacturers chose to put the W in front of wingless clamps. So this is a W2A with wingless. This is a W7 wingless. Um, so the 14A has no W, so it indicates it has wings. And those wings are just so that you can hook the rubber dam over the top of it. Sometimes you can put this clamp in first and then the rubber dam over top. With wings, you can put the clamp on the rubber dam and then slide it in. So it's just a different way of doing it. But again, it's hard for me to explain to you. You have to put them in the mouth and work with them. And this would be one that you use on anterior teeth. So again, just a whole bunch of different clamp sizes that you're going to use at different offices, and 2 different styles of rubber dam punch and different styles of rubber dam clamps, forceps. So here's how it typically works. You put some floss on the clamp in case that's so that if it flies off that it doesn't fly down the patient's throat. Or if it does fly down the throat, you can easily retrieve it with the floss. And then the rubber dam goes over the clamp, and then you floss if you're going to do multiple teeth, to get it in between the teeth. There are rubber dams that come with a frame already inserted into them. Those are, some offices use them. Just depends on what your office uses. So here's a video about rubber dam placement. This is often it's required of the assistants to place the rubber dam, so you need to be familiar with how to do that. And the patient is going to be numb when you're using a clamp. So most often, there's occasionally when they might not be, but that would be for an experienced dental assistant. So most of the time you're going to be numb when you're placing a rubber dam.
The dental dam, clamp, and additional supplies and equipment are prepared and ready. Grasp the rubber dam forceps with clamp already positioned and seat the clamp by placing the lingual jaws of the clamp first, followed by the facial jaws. Maintain your finger on the clamp to prevent it from coming off before it has been stabilized on the tooth. Take the dental dam to the site and stretch the punched hole for the anchor tooth over the clamp. With cotton pliers, retrieve the ligature and pull it through the dam so that it is exposed and easy to grasp if needed. Position the frame over the dam and slightly pull the dam, allowing it to hook onto the projections of the frame. At the opposite end of the anchor tooth, stretch the punched hole of the dam over the last tooth to be exposed. Stretch the dam on the lingual and facial surfaces of the teeth so the dam can slide through the contact areas. With a piece of dental tape or wax floss, floss through the contacts, pushing the dam below the proximal contacts of each tooth to be isolated. Inverting the dam can be accomplished by applying air to the tooth or by using a black spoon to invert the edges of the dam. The dental dam application is complete. When removing the dental dam, remove the ligature from the dam and slide your finger under the dam parallel to the arch and pull outward so that you are stretching the holes away from the isolated teeth. Using crown and bridge scissors, cut from hole to hole, creating one long cut. When all septa are cut, the dam is pulled lingually to free the rubber from the interproximal space. Using the rubber dam forceps, slide the clamp from the tooth, removing both the dam and frame at one time. Inspect the dam to ensure there are no pieces of the dam missing. If a fragment of the dental dam is missing, use dental floss to check the corresponding interproximal area of the oral cavity.
So I don't love that video because it's not on a live person, but it does give you an idea of the how the rubber dam works. So don't get too hung up on that. On maybe she didn't know what she means by invert to the parallel, whatever. Just know that rubber dam is a very common thing, and you need to be aware of how to use it. So practicing on a mannequin is a good way to get familiar with how to use it. Okay, so four-handed dentistry, as the title of this module said, is the dentist's two hands and the assistant's two hands. So 2 plus 2 is 4. And how the assistant sits in relation to the dentist is really important. So if you'll notice here, they're working closely. The assistant is very close to the dentist. If you could see their knees, if his knee, the way I tell my assistants, if my knee is not touching your chair, you're probably not close enough. So you need to be in there up close and personal so that you can see down into the patient's mouth. Okay. So one thing to note is how her head, the assistant's head, is above the doctor's head. So this is a different view. The other view was looking from the patient's waist. This is looking from behind the patient. So the assistant's on the other side now. So the assistant their head is above the doctor's head. This light's in the wrong place. It should be up higher so that it's not in the way of the assistant seeing straight down into the patient's mouth. So, but notice that the assistant should be a little bit higher than the dentist. So looking down straight from above, this white outline is the patient's bib. The assistant is over here. So we often think of it in a clock. Okay. So 12 o'clock being the top of the patient's head. So the doctor's sitting at the 11 o'clock position. The assistant is very often in the 2 o'clock position, usually not up as far as the 1 o'clock position, but very often in the 2 o'clock position. This would be as far down the clock as I would want the assistant to go. The transfer zone is between the 4 and 7 o'clock position. It's down here. And usually I just tell my patients over the patient's bib. If you're handing instruments over the patient's bib, you're going to be safe. You should never hand instruments over the patient's face. We really want to protect our neck, back, and spine. 30% of all dentists and assistants, well, I don't know about assistants, but I know that 30% of a dentist, a lot of them will leave their practice early in their career because of back and neck problems. So we want to protect your back and neck. We want to try to keep that spine as straight and in its natural position as we possibly can. And that has a lot to do with the position of your chair, the position of your neck and back as you're working in your arms. So utilizing the assistant chair properly is important. So if this assistant has their elbow at a 90 degree, they're supporting their weight of their body on their assistant chair, the assistant arm. The dentist is sitting up straight, looking down with his eyes, not so much with his neck, as much as possible. The assistant is holding the high volume suction tip and the assistant or the air water syringe tip properly. That keeps her neck and back in the aligned position. So same thing here, neck and back straight up. She's using her eyes to look down more than her neck. The dentist is wearing loupes. So a very good, you notice her arms at a 90-degree angle. It's resting on the armrest. So she's going to have a long and pain-free career. So what do you see here? She's leaning on the armrest with the weird arm, with the different arm, and she's pointed away from the patient. So I'm not thrilled about this particular assistant's ergonomic position. So she's better. This is a stage. This isn't an actual operating position. This is a stock photo. Now this one is one of my favorites because it's one we see so commonly. Her back and neck are obviously in a giant curve. She must really like this patient because she's just up close and right up in her business. Notice her hair is kind of drooping over the patient. Um, but this is a very common problem for new dental assistants. They scrunch down like this because they want to see closely, and they have trouble uh, sitting up straight and straightening out their back and neck. But this is, again, one of my favorite because it's so bad. So same thing here. You're going to look at how long do you think she can hold this position with her shoulders and arms up in the air like this? Don't like that one. Okay, what do you think about this one? She's bent over. She's super close to the patient. See, I think that's a very poor posture for a dental assistant or a hygienist. Okay. Much better position here. She's using opposite hands. I would recommend that the high volume suction always go in the right hand and the air water syringe in the left hand. She's got her neck a little crooked, more crooked than I would like. She's not using an assistant stool, so she doesn't have an arm here to rest her arms on. So I'm not crazy about her assisting career. Some dental assistants in some offices stand. That's not unheard of. It's not terrifically common, but it's possible. This can be, she's much, much higher than the dentist. Notice how she's curved. She's going to have to bend way over. It's going to be hard for her to see exactly what's going on. Okay, what do you see here? What do you see here? What do you see missing from here? But her posture is generally pretty good. Her arm's at a 90 degree. How about here? By now you should have a general idea that I'm probably not wild about this particular assistant and her position. Probably a stock photo, although this would be a common scene. Okay. So good ergonomics is important, and it makes dentistry much, much more enjoyable. So again, you look back at that previous high vac is in her right hand, air water syringe in her left hand. Same thing here. Sitting up straight, back and neck as straight as they can be. Okay, the light. Pop quiz, answer true or false. The assistant is responsible for adjusting the overhead light so the assistant can see. Is that true or false? False. What one word can change to make that statement true? So the doctor can see. That's what's critical. If it's done properly, both of you get to see. So positions of the light directly over the patient's mouth and adjust there from there. So start over the patient's mouth. Light travels really fast, 186,000 miles per second. So you don't have to have it really close. As we mentioned in that ergonomics section, that light was way too close. It needs to be up as far away as you can get it and still be pointed at the patient so that you can move it. Patients judge their treatment based on the cleanliness of the operatory very often, and that's what they see a lot. So if there is splatter up here on the lens or up here on the mirror, they're going to see that, and they think that their treatment is terrible if their light is dirty. So make sure that as part of cleaning the operatory that you know how to clean the light. The mirrors on the newer lights have to be cleaned very carefully so they don't get scratched. So know how your office wants you to clean the lights. Don't just grab a paper towel and go rubbing them on there because that will scratch them. So learn how to clean it. Try not to shine it in the patient's eyes. That's just polite. And kids often very sensitive to light. So some kids really don't like that dental light over their face. So you should practice that when you sit down with your classmates. You should be practicing using the light. Okay, we're going to have a short video about the transfer zone and handing from doctor.
There is a specific place where instruments are to be properly handed to the dentist. The handoff should be made below the patient's chin and never over the patient's eyes. Essentially, the transfer zone is over the patient's bib. So the blue area in this video is the patient's bib, and that is the transfer zone. If the transfer goes poorly and the instrument is dropped, it will not enter the patient and will land harmlessly on the bib. Again, instruments should never be handed over the patient's eyes or face in case there is a problem in the transfer and something is dropped on the patient. So the assistant stands ready with the instruments over the transfer zone. You may recognize these instruments as being used for a composite filling procedure. The assistant's hand stands ready to receive and deliver instruments over the transfer zone, which is essentially the patient's bib. You'll notice also that the doctor's hand is rarely empty. The assistant is anticipating the doctor's next need and preparing it over the transfer zone to transfer to the doctor. You'll notice here that the assistant is holding the air-water syringe in a method so that she can deliver it to the dentist after receiving the instrument out of his hand. She switches to the high-volume evacuation tip for just a few moments, and we go back to delivering instruments to the dentist over the transfer zone. Note again that the assistant stands ready with the next thing the dentist will need. She's not waiting until he's finished with the instrument that's in his hand. She's prepared with the next instrument. Sometimes it's materials, sometimes it's instruments. In this particular case, she stands ready to receive the air-water syringe and deliver the microbrush. Now you noticed her hand there, she transferred the air-water syringe to the top of her hand to be ready to deliver and receive it once again over the transfer zone. That's something you'll learn as an advanced dental assistant. But you should be aware of things like that. So once again, remember the transfer zone, never over the patient's eyes and face, always over the patient bib, and always be ready and thinking ahead of the dentist. This dental assistant should be thinking about 2 steps ahead of the dentist in the procedure. If you were to number the procedure steps, the dentist should be a couple of steps behind the assistant. The assistant should always be thinking ahead. She knows what's coming next, and she prepares it over the transfer zone, very close. The dentist doesn't have to move very much and receives the instruments in a quick and orderly fashion. It's one of the most important things that a dental assistant needs to understand is how to transfer instruments in the transfer zone.
Okay, so we're going to move on to the high volume evacuation, or the high vol suction, or the high suction. You'll hear it called several things: the high vac, vac being vacuum, the high vacuum. So you have the slow volume and the high vac, or the saliva ejector and the high vac. Everyone will call it something different. So the doctor assistant position. So the doctor's coming in. So in the upper right hand quadrant, tooth number 3, 4, 5, 6. Remember your tooth numbers. So if I were to draw a line from here to here, that line would parallel a line drawn along the teeth. Okay? So roughly parallel. Same thing over here. If I were to draw a line here, it would parallel a line drawn along the edge of that high volume suction tip. Okay? So the bevel always faces the teeth. This is the bevel. This is where it's cut off at an angle. That's a bevel. So on the lower, so again, coming from the patient's left side, this was the assistant, that bevel is paralleling the sides of the teeth, and on the right hand side, that bevel parallels the buccal surfaces of the teeth. So this is parallel to the lingual, parallel to the buccal. Okay? Tooth number 19, 22. Get those tooth numbers down. Okay, so another view in the assistant's right hand, that bevel is parallel to that tooth. That's tooth number 19. Okay, and notice how it's down inside the cheek a little ways so that it doesn't flip out. And then the air water syringe stands ready to help. Okay, so here's a video going to walk us through that.
High volume evacuation is one of the most important things a dental assistant is going to do for the dentist and for the patient. First of all, we're going to have a short demonstration of the low volume suction, also known as low volume evacuation or saliva ejector. You can see how the dental assistant uses her thumb to operate the on-off switch. That's on, that's off. There is no reason to have the suction partially on or partially off. It should be all the way on or all the way off. The other thing that dental assistants use most is the air water syringe. She's going to use her thumb to operate it. Notice how it's held. So it's just like a pistol grip. The thumb operating either one or both buttons. You will have to get used to which one is air and which one is water, and they will become second nature to you as you use them. But you have to sit down and practice using them. You can't just hope to watch this video and know how to use them. One place you might use the saliva ejector is right after local anesthetic. You would wash the patient's mouth with air and water both, and then allow the patient to spit into the saliva ejector. The dental assistant will pick up the high volume evacuation either with the left hand and hand it to herself or himself with the left hand, or she'll pick it up automatically with the right hand, and it is immediately ready for use. With the left hand, she's going to pick up the high volume evacuation. Is operated the same way as the low volume, with the thumb turning the rocker switch on and off. It's again either all the way on or all the way off. There's no reason for it to be only halfway on or halfway off. Most of the time the high volume evacuation is used while a procedure is being taken place and is not for the patient to close around or spit into it. So here is being demonstrated when you would be blowing air or water into the patient's mouth and evacuating with the high volume. Now let's take a look at the assistant's posture while using the high volume evacuation. One of the biggest mistakes we see new dental assistants make is to try to lean over and get really close to the patient. You can see how she picks up the suction and then she leans slightly forward, but she doesn't lean over the patient. She leans just forward enough to get a general view of the area. This posture will keep her back and shoulders from tiring out during the procedure. The dental assistant will have to switch between the high volume and the low volume evacuation instantaneously so that she can keep up with the procedure. Again, notice the posture, notice the hand positioning. Okay, so now it's important to look at the end of the high volume suction. I want you to notice the bevel or the sloping of the suction tip, how it is flat with the surface area of the inside of the teeth. So if we're working on the top right hand side, she is right next to the area. Say for instance we're working on tooth number 3, the operator is going to enter the mouth, her high volume suction tip is already there, and then her air water syringe will approach the mirror and blow air off the mirror. If she needs to wash the tooth, which she should do instantaneously after the operator leaves, she can do so immediately. That's one of the big mistakes we see dental assistants make, is leaving the mouth too soon. Once the operator leaves, now it's your turn to stay in the mouth and work in the mouth, because usually the operator is leaving only because they can't see or they have to change instruments, but you need to go in and wash things. So again, the top left hand side, see how the bevel is parallel to the teeth. So again, top right hand side or the bottom right hand side against the patient's right hand side. That's the way we speak of things, is patient's right or left. So the patient's right hand side, patient's left hand side, the cheek is going to be retracted with the high volume evacuation tip. And again, the bevel or the slope of the high volume evacuation is parallel to the side of the teeth. We're going to view it from the dental assistant's perspective now, as if we were inside the dental assistant's head. You can see again the hand position. Again, the air water syringe on the mirror, and the suction tip is close to the procedure as can be. So that was the top right. Here is the bottom right. And the operator comes in. And the operator may or may not use the mirror in that particular spot. As we've demonstrated both there. You'll need to practice these. You need to spend some time practicing these. These hand positions. This is not something you can learn just watching this video. You need to sit down with a real patient in the chair and practice these movements, as they are most important to the dental assistant.
All right. So again, the transfer zone is really important, and the positioning of the suction tips, and utilizing your instruments to keep your back and neck straight. Instruments similar to these will be passed lots of, throughout the whole procedure. So be sure that you understand that, how to do that. If you'll notice the assistant's hand, instrument is held clear to the very end, as far to the end as that assistant can get. The little finger is extended as far as it can go, so there's a big landing space for that dentist to transfer the instrument to that assistant. That assistant curls in their finger and accepts that instrument, and then extends this instrument out to present it to the doctor. This is again something you have to practice, and you can practice it at home with yourself. Mostly you'll be transferring with your left hand, whether if your dentist is right-handed, or with your right hand if your dentist is left-handed. So you need to know, generally most people obviously are right-handed, but there are some left-handed dentists out there, so just be aware of that. But the principle is the same. You hold the instrument at the very, very end here, as far so you can give the dentist all this space. You don't want to hand the dentist can't reach the patient if their hand is here and they have this little short area. The dentist needs to grip the instrument as far up as they can up on the handle. So you need to be gripping it as far down the handle as you possibly can, as far away from the middle as you can. And then that little pinky needs to be extended out there. But this is a person practicing with themselves how to transfer instruments. Okay, and just remember, never over the patient's face. So shorting the instrument would be, as I mentioned earlier, if the assistant is holding the middle of the instrument. Now they're going to give the doctor this part of the instrument. That is totally wrong. So that's called shorting. So these fingers should be all the way up here at the very end. That is where the assistant should be holding it. Okay, again, just to review this, lower right hand quadrant, the bevel facing the teeth.
If there's one skill that I need to impress upon your mind, that you need to master it, is transferring instruments. You must practice this. Please master this skill. This will do more for you than any other thing we can teach you. It begins with getting close to the dentist. You need to slide right in. You can see how the knees overlap. The dentist's knee is between the assistant's knees. Please position yourself properly. So now the transfers begin, and you'll notice how smoothly and efficiently these go. There's not a lot of movement between the two. The assistant firmly places the instrument in the dentist's hand. He receives it quickly. This is how our trained dental assistants transfer instruments all day long. Notice her little finger receives, grips it, immediately gives the dentist the other instrument. I'm going to pause it here, little finger way out there so that it's an easy target for the dentist. I call it a runway. Just give him a runway to land that instrument right in there, receive that next instrument. Most instrument transfers happen this way. You need to practice this at home with butter knives, whatever you can. Practice this with someone at home. Get these down. Here's the air water syringe being passed with the micro brushes. We have a whole separate video just on passing micro brushes. But it's no different in this particular case than receiving any other instrument. The composite gun is received the same way. Assistant a little bit behind there. She needs to be ready with that next instrument if at all possible. She knows what it is, and she should be thinking about 2 steps ahead of the dentist. So all instruments should be received in a quick, efficient manner. Instrument transfer will not come without practice. You've got to drill yourself, get this skill down. It means the difference between success or failure as a dental assistant. Practice and drill yourself.
Okay, the dentist's mirror. So dentists work upside down and backwards. We work upside down. We're looking at the patient upside down, and we're looking in a mirror much of the time. And then we're also underwater too, or at least under spit. So that mirror is critically important to us. Things that block the dentist from seeing the mirror is fog. So because the mirror is colder than the patient's breath, just like water condenses on a glass of ice water in the summertime, the water from the patient's breath, or the moisture from the patient's breath, will condense on the mirror and fog it up. So that's how that works. Water from the procedure, dust from the procedure from cutting the tooth, saliva splashing around, blood gets on it. What can you do about that? Well, as a dental assistant, you have 3 functions of your air water syringe. One is just air, one is just water, and one is both air and water. So you can use those functions to keep the dentist's mirror clean. The air water syringe tip, so this is the air water syringe and this is the air water syringe tip. Some of these are disposable and some of these are autoclavable. If it's metal, meaning they're autoclavable, they're sterilizable. If they are plastic, then they're probably disposable. Which end of the syringe tip goes into the syringe? This end goes inside. So obviously that would hurt if you poked a patient with it. Make sure that that's the end that goes in and locks in. You have to practice using this. It's very difficult to describe to you how to load these in, so you need to practice using them. So the dental mirror fogs, for the same reason your bathroom mirror fogs. It's cooler than the steam that comes off your shower. So just know that that's why the mirror fogs. A light air blow will keep the mirror clean. It may not need to be full blast. It does not need to be really close to the mirror, and do not get between the dentist and the mirror. Light travels in straight lines, So if your dentist's mirror is going to be straight in front of his eyeballs, don't get in between the mirror and the dentist. So again, you have two buttons with three functions: rinse, wash, dry. So rinse would be just water, wash would be air and water, and dry would be air, right? So water and air buttons at the same time, and dry would be the air button only. When might you need to wash something? When might you need to rinse something? So wash would be if I was going to wash out a lot of debris from the patient's mouth, if I was going to wash off the mirror, if I was going to wash the anesthetic out of the patient's mouth, I would wash. If I was going to rinse, it's not very common to use just rinse, but sometimes you just need just water. You don't want anything else. In surgery, you might just rinse without blowing air. And then dry, a lot of times you need to dry the water out of a cavity prep after the dentist has worked, drilled a hole in something, because you need to wash the debris out so he or she can see inside there. The one big mistake, one of the biggest mistakes that a dental assistant probably will make, is when the dentist is preparing a tooth, there's a lot of debris and dust flying around. When the dentist stops drilling, they stop for one of two reasons. Either they can't see anymore, or they're finished with that part of the procedure. If they can't see anymore, or they're finished the procedure, it doesn't matter. The dentist always does the same thing. Okay? The dentist jumps in and goes to work. Okay? When the dentist leaves the mouth, the dental assistant takes over. It's now the dental assistant's mouth. For the next 3 seconds, the mouth is yours, so you own it. So what do you do with that? You wash. Okay, you're going to wash air and water. Now, I'm not saying rinse, I'm saying wash. Air and water blast directly into the preparation and blast all the dust and fluid out of the preparation, okay? That's the first 1 second. The second second is you're going to suction. You're going to suction the corners of the mouth. Remember that where the pteromandibular raphe is? You're going to suction those areas. That's where most of the water is going to go. So you're going to suck that out, and you're going to use the air water syringe to prevent the suction tip from sticking to the tongue and the cheeks. And then the last thing you're going to do, you're going to dry the area. The dentist cannot see through blood and water. Dry the area before you leave the mouth. If the dentist is still there, be sure his mirror is clean. Okay? So when the dentists leave the mouth, it's for one of two reasons, right? Either they can't see anymore, either the mirror or the tooth is blocked so they can't see, so they're going to clean their mirror, or you need to clean the tooth. And the second reason would be is if they are finished with that part of the procedure. Either way, you do the same thing, which is wash, suck, dry. Pretty quickly, it goes about this fast. Wash, psh, suck, psh, suction, suction, dry. Psh. So, it's about that fast. You have to practice this. You have to sit down and practice this on each other in the clinic. I hope you will do that. So again, where should the dental assistant be mentally? It's mentioned a couple of times in that video, and I've said it a couple of times here. You should be 2 steps ahead of the dentist. In your mind, you should be thinking, what are the next 2 things we're going to do, so that you can be looking for those instruments, preparing for them, making sure they're in the room. You've got to be 2 steps ahead of the dentist. In order to make sure you have the correct materials and everything arranged, you got to think about the next 2 things that will happen in the procedure. Okay, dental handpieces. Again, we have the high speed and the low speed, and we'll go through a short video here on that.
Today we're going to discuss the differences and similarities between high and low speed handpiece assemblies. These are not the only kinds of high speed and low speed handpieces you will see, but they are very common. Some particular things you need to notice about the low speed handpiece is that there's different sections. There's a bend to it. It's called a contra angle. It also comes apart by pulling apart with your fingers. And this is a latch type, so it has a little swinging latch that will secure the burr into the handpiece. So we take the burr, it has a little notch on the end of it, you'll notice. It's much larger than a high-speed handpiece. And it is inserted and rotated until the little flat spot meets the flat spot inside. You can see it comes all the way through, and then the latch is closed to hold the burr in place. And that's tested to make sure that it won't come out. So that's the low-speed handpiece. The high-speed handpiece runs much higher speed. This is a push-button type chuck. So the thumb pushes the button and the burr is inserted. It's checked to make sure that it's in all the way. You don't want to run the burr half in or half out. That's hard on the handpiece. This is the swivel area for the handpiece. Many handpieces will swivel. And again, you push the button with your thumb to engage or release the chuck, and the burr should slide out. Push the button on the chuck, insert the burr. Check it to make sure that it's secure. Handpiece is loaded with the burr. So this is the hose for either the high speed or the low speed. We're going to count the number of holes here. You can see that this is a 5-hole assembly. This will match up with the high speed handpiece. Large hole to large hole, small hole to small hole. And you can see how the handpiece is threaded. It will be threaded onto the hose. Now notice there's thread still remaining, so we know that it's not tight. On many or most handpieces, the thread should be completely buried inside the hose and then tightened securely. If you don't tighten it securely, water will spray out of this area and it becomes highly inconvenient. The dental assistant must be aware of how a properly installed handpiece looks and feels and works. We'll move now to installing the low-speed handpiece motor onto the hose. You'll notice the low speed in this particular case only has 2 male ends that will slip into the female portions of the hose. The gasket has the holes for the high speed, but it is not being utilized by the low speed handpiece. You can see there are no extra tubes there. The gaskets are interchangeable and can be removed and replaced. They need to be replaced periodically. As you can see, the large hole will match up with the large hole and the small with the small. And again, threaded carefully. Should thread very easily. You want to make sure that it goes all the way up. But you can see that there's a swivel on this particular motor, so it needs to be pulled apart. It's very difficult to pull these apart. It has a separate swivel assembly, so that you'll need to hold to tighten that on there with. And once it's tightened on there, then the motor can be inserted onto the swivel, and it's just pressed on there. It's a press fit that holds it together. Then the fingers are used to draw back part of the contra angle and clip onto the motor, and the handpiece is ready for use.
Now those are just 2 different kinds of handpieces. There are many, many different kinds. Those are representative of what you might see, but you're going to see other different kinds, so you need to be familiar with handpieces in your office. But generally, high speed and low speed, if you know the difference between them, you're going to go far. Handpiece maintenance, every office is going to be different depending on the handpiece, but they often need to be oiled and sterilized, so you need to know what the procedure is for your office and how to oil them. They have special machines to oil them and sprays, and some offices have this machine that automatically cleans and oils them, and then they go into the autoclave. Again, this hairstyle would not fly in my office. Okay, setting up the treatment room for the patient. Every office is going to be different again. There are some general things to handle: the light, the chair, the instruments. Some offices will use plastic bags over every instrument. They'll use a big plastic bag over the chair. Some offices will not. Some use just a headrest cover. Some will not. Everyone's a little bit different. Every office is a little bit different. We'll see how this office does it.
At the beginning of the day, apply an appropriate surface barrier to clinical contact surfaces before seating the first patient. These surfaces will have already been cleaned and disinfected at the end of the previous day. Place each cover so that it protects the entire surface and will not be dislodged when touched. When removing surface barriers between patient visits, wear gloves. Either the exam gloves worn during the procedure or utility gloves are acceptable. Use care not to contaminate the surface beneath the barrier. If the surface is touched when removing a cover, such as by a contaminated glove or with the unclean side of the barrier, then that surface must be cleaned and disinfected. If the surface has not been touched with contaminated gloves or by the contaminated side of the barrier, cleaning and disinfection is not necessary.
And I would disagree with that a little bit. I think that all surfaces should be disinfected after every patient. As many surfaces you can possibly clean should be cleaned, because you just don't know if they've been touched or aerosol from the treatment has settled on them. So in my office, my assistants wipe down many surfaces when they're preparing for a patient. Setting up for treatment, seat the patient, place the bib on them. Your instruments and materials will probably already be in the room. I would hope that my assistants always set up the rooms long before the patient arrives. A lot of offices use a tub and tray system where they have instruments on one side and then different disposables and materials in a tub next to it or nearby. Again, you anticipate what the doctor is going to be doing. How many steps ahead? 2 steps ahead at least. You need to know that if you're going to have post-operative instructions printed, they need to be printed and ready for the patient. You need to enter the treatment into the chart. Most commonly, it's often the assistant's responsibility to enter the treatment into the chart. It's almost every office is going to be computerized now. There are those rare paper offices, but everyone's going to be on a computer. The route slip is often a piece of paper that follows the patient through the office. Some offices will use it, some will not, but you need to understand that it's what it's called usually as a routing slip that follows the patient from the front desk all the way through treatment and back to the checkout area. And you should escort your patients and hand them off by introducing them to the person that's going to speak with them at the front so they can pay their bill or make their next appointment. Cleaning the treatment room, sharps go in biohazard containers. Some states, all waste, gauze, everything goes in biohazard. Some states don't require that. Just need to understand what is the regulations in the office that you're working in. One thing that's going to be very common though is anything sharp, anything that could be broken and poke someone should go in a sharps container, which is a plastic container with a lid that cannot be removed. So once it's in there, you can't just reach in and grab stuff. So another short video on treatment room disinfection. Again, it's not sterilization, but it's disinfection. Remember the difference between those two.
When performing treatment room cleaning and disinfection, the dental assistant is wearing PPE and utility gloves, goggles, and a mask. Check to see that the solution has been prepared according to the manufacturer's instructions. The dental assistant removes contaminated barriers and disposes of them in the general waste. The first step in the cleaning, disinfecting, 2-step process is to clean, starting with the patient chair at the head and shoulder area, which are high areas for contamination. Any surfaces that are not protected with barriers or have become contaminated during removal of the barriers must be cleaned and disinfected. Be careful not to spray into electrical switches or components. All potentially contaminated surfaces must be cleaned and disinfected. This includes the operator and assistant stools, as well as the adjustment handles. Next, spray and clean the surface of the dental unit. When cleaning a large area, it may be necessary to use several paper towels or gauze pads to avoid simply spreading the bioburden instead of removing it. Smooth surfaces are easily cleaned and disinfected with paper towels or a gauze pad. To reduce overspray when cleaning hoses, place a paper towel behind them when spraying and wipe using the paper towel. To disinfect all surfaces after cleaning, repeat the preceding steps in sequence, allowing all surfaces to remain moist for the manufacturer's recommended time.
Okay, so again, your office is going to have different different treatment room disinfection protocols, so you need to learn those. Sterilization procedures, again, these are going to be general principles. Every office is going to be slightly different, but there are general principles. So remember, there's a difference between disinfection and sterilization. Disinfection is when you're just killing nearly all the bacteria, viruses, and spores. Lysol is a popular brand of disinfectant. Sterilization, when you kill everything, you kill all viruses, everything, so there's nothing alive. And this is usually accomplished in a machine called an autoclave. Sterilization most often happens with heat, but it can happen with cold sterilization. You sit in a chemical bath, the instrument sits in a chemical bath and kills everything. It usually takes over 20 minutes for that to happen. Sometimes as long as a couple hours, depending on the chemical bath. You wash the instruments and then heat them in the autoclave. Yeah, ultrasonic and heat is another common way. And sometimes you wash in an ultrasonic bath and then heat the instruments. She used the word bioburden in that video. Rather than spreading the bioburden around, you're trying to clean it off. So that's one of the things the ultrasonic and the washing would do, would be to clean off that bioburden. Cold sterilization, this is one brand. You usually would see them in a box like this, and then it has a little instrument carrier, and again, minimum of 10 minutes, but it depends on the material being used. Ultrasonic cleaners often look like this. They have usually a 20-minute cycle time where they send ultrasonic waves through the fluid inside, and it's usually an enzymatic fluid that dissolves blood and biomatter. So you don't want to get that on you. I mean, it's not necessarily harmful to your skin, but it's not great either. Another short video on general sterilization principles.
When operating the ultrasonic cleaner, the dental assistant should wear PPE and utility gloves. You will be handling sharp, contaminated instruments and using a chemical ultrasonic solution that could splash in your eyes. Raise the lid on the ultrasonic container and check that the level of the solution has been filled to the level recommended by the manufacturer. Place the basket into the ultrasonic cleaner. Close the lid and turn the cycle to on. The time of the cycle may vary from 5 to 15 minutes. After the cleaning cycle, remove the basket. Hold the basket at an angle and thoroughly rinse it in a sink under running water with a minimum of splashing. Gently turn the basket onto a towel and remove the instruments or cassettes and close the lid on the ultrasonic cleaner.
So autoclave, it's a pressurized chamber, uses heat up to 275 degrees under 20 pounds of steam pressure. The purpose for the pressure is to force that steam into all the small places all around the instruments so that nothing can escape the sterilization procedure. Loose instruments should be wrapped and put in a pouch. Is a very common thing. You can either use a cassette. Some offices use a cassette or pouches after they've been obviously ultrasonic. They can be ultrasonic in here, but they are not ultrasonic in a pouch or a pack. But usually they're wrapped before they're sterilized so that you don't have to open these until you're ready to use them, so they can stay sterile until they're ready to be used.
Prior to autoclaving, the instruments must be clean, but not necessarily dry, before wrapping. Place the instruments in an autoclavable pouch, label, and seal. Place the bagged items in the autoclave. Separate articles and packs from each other by a reasonable space. This permits a free flow of steam in and around all instrument packs. Check to be certain that an adequate supply of water is present. If not, add distilled water. Always follow the manufacturer's instructions. Never overload the autoclave. Set the autoclave controls for the appropriate time, temperature, and pressure. At the end of the sterilization cycle, vent the steam and allow the contents of the autoclave to dry and cool.
And autoclaves will look different. Those are very common mid-mark autoclaves. That's the brand name, just like Ford, Chevy, or car brand names. But every office will have a slightly different operation for those autoclaves, so you just have to learn that when you get to that office. Autoclaves loaded, instruments loose, ultrasonic fluids are changed regularly. Don't pick up dirty or non-sterile or even sterile instruments. You should be wearing gloves. Keep the sterilization room neat at all times. Sterilization rooms often have a dirty side and a clean side, so be aware of that. The instruments flow through the room from a dirty to clean area, so you need to be aware of that. And use heavy-duty gloves when handling instruments in the ultrasonic cleaner. So again, usually that's divided into sterile area and non-sterile areas, so as not to confuse the instruments. Sharps containers very often are in the room, treatment rooms. Sometimes they're not. In my office, we have a sharps container in every room so that they can be handled immediately and we don't have to worry about them. Wipe down all the countertops, spray the hand pieces, wipe down all the chair and lights, dispose of any sharps, remove the dirty instruments to the sterilization area. Okay, so that gives you another piece to the puzzle of dental assisting. I hope you were able to get some things out of today, and thanks for listening.